Good afternoon. My name is Joe Walsh. On behalf of myself and Dr. Boryicki, I would like to thank the conference committee for their invitation to present our paper today on a resilience model for moderating the outcomes related to electronic medical record downtime. Unexpected information technology downtime occurs more and more often with widespread adoption of electronic systems in healthcare. As patient care becomes more dependent on these diverse electronic systems, clinical staff are also becoming more sensitive to the availability of systems in patient care areas. Although technology has the potential to make patient care safer, multiple reports of patient safety threats related to health information systems, particularly during systems outages, highlighted the unintended consequences of integrating technology into healthcare delivery. Downtime, in essence, is the time during which a system or piece of equipment is not functioning properly or is otherwise unavailable to users. That could mean systems have partial functionality, but the organization is still in downtime procedures, like when, for example, an admissions module is down. The purpose of this study is to see what published information exists about EMR downtime planning and what organizations are currently doing to prepare for downtimes. We know that publications have reported many aspects of EMR proposals, design, and implementation, all the way through to post-implementation training. As organizations experience downtime after implementation, workarounds and contingency plans begin to develop as a solution to the temporary unavailability. These formalized plans become the first basic steps of mitigating the effects of EMR downtime. The research objective for this study was to examine the extent and nature of published research that currently exists in the body of knowledge concerning EMR downtime planning in a clinical setting. From these results, we expect to derive a model that demonstrates the impact of downtimes and how organizations can moderate the effects of a clinical downtime. This study follows the scoping study framework described in 2005, defining a method for literature review. The scoping study method was selected as it is, quote, guided by a requirement to identify all relevant literature regardless of study design. This method allows for a broader inclusion of articles in a topic where potentially few published relevant studies exist. This study will follow the 5 mandatory stages of the scoping study methodology and included the 6th optional stage of consultation with subject matter experts to review and sharpen the findings. Here is our study inclusion criteria. Patient safety or quality of care was only relevant in this study if it was directly related to downtime events, or if it was listed as the root cause of a patient safety issue in incident reports. Downtime mitigation is any deliberate activity aimed to reduce the severity or impact of a downtime event, either before, during, or after a downtime. Downtime contingency plans are formal plans designed to guide staff on appropriate procedures in the event of a full or partial systems downtime. Studies included must be peer-reviewed, published in English, and have their abstract and full text available electronically. In this stage, we define the search terms used. In this case, we use logical OR operators to group similar terms like EMR or electronic medical record, as well as logical AND operator to include the required term downtime in all results. That gives us the complete term shown here and in the paper. This table shows the number of articles that were returned from the initial database searches. Because of the nature of the topic, we used Medline, PubMed, CINAHL, IEEE Explore, Web of Science, Biomed Central, and Applied Science and Technology Index. This Prisma diagram demonstrates the flow of included and excluded articles throughout our selection process. 672 articles were found initially from all sources. Search results were imported into EndNote for Mac and scanned for duplicates. That left 625 non-duplicate articles for title screening. Following title screening, 595 articles were excluded, leaving 130 to advance to abstract screening. After a more in-depth screen of abstracts, 100 additional articles were excluded based on relevance. The remaining 30 articles advanced to full text screening, where 4 were excluded for context, leaving 26 articles published between 2008 and 2021 to be used in data extraction and charting. All were included in the findings. Now that we've reviewed our methods, let's discuss some of our results. We found several causes of downtimes in the articles that were reviewed. First of all, planned downtimes commonly take place for scheduled maintenance and updates. Downtimes are also typically associated with systems failures, such as application failure, communications failures, or server failures. One article noted that operator error had caused a configuration issue that led to the downtime of a critical patient care system that lasted for several days. There are also several documented cases of downtime associated with natural disasters like hurricanes, floods, and earthquakes. Several articles have documented the mitigation and remediation of systems following Hurricanes Katrina in 2005 and Sandy in 2012. Finally, cybersecurity breaches such as ransomware were the single most common cause of reported unexpected downtimes, accounting for 48.8% of downtimes reported between 2016 and 2018. We also found empirical evidence that documents the patient safety outcomes associated with downtime. The patient safety outcomes present in the literature included increased overall surgical times and longer postoperative length of stay. We also found evidence of adverse clinical outcomes and adverse patient outcomes. There is empirical evidence to demonstrate that downtime contributes to clinical errors, including medication errors. And finally, we found studies that demonstrate an increase in lab study turnaround times, which delay the reporting of results and contributes to delay in diagnosis and treatment. We also found several moderating variables to the effect of a clinical downtime in the literature. Among these, we found several examples to support that contingency planning and mitigation strategies can lessen the impact of a clinical downtime. We also found that building out systems redundancy can minimize the likelihood of a systems error that causes lengthy downtime. And in the event of a significant disaster, backup systems and procedures can minimize recovery efforts. Following our consultation sessions with subject matter experts, we've created this model. As we can see from the literature, there is strong empirical evidence to support that disasters that initiate an EMR downtime leads to several patient safety outcomes. Researchers have demonstrated that downtime-exposed patients experience a 4% longer procedure time in the OR and 10% longer overall length of stay. There is also evidence to support that downtimes lead to adverse clinical outcomes, including clinical errors and medication errors. Downtimes can additionally have an effect on lab study turnaround times that delay patient test results and can also delay diagnosis and treatment. Additionally, we found evidence to indicate that contingency planning and mitigation strategies can lessen the impact of a disaster. Redundancy in systems deployment and strong backup strategies can both moderate the effects of a downtime on operations and improve or prevent lengthy recovery times. With electronic medical record systems being deployed in healthcare organizations, clinician reliance on these systems for patient information has increased. When those systems experience downtimes, they create gaps in information and care processes that can influence patient safety and the continuity of care of our patients. Data gathered from incident reporting tools, as well as in-depth analysis of lab study turnaround times, have provided valuable insights into the clinical impact of downtime events. The activities identified in this model, contingency planning, mitigation strategies, systems redundancy, and backup systems, can be used to modify the patient safety outcomes associated with downtime. EMR downtimes are inevitable, and downtime planning has shown that it can mitigate or moderate the impacts to patient safety and quality of care. Regardless of the nature or cause of the downtime, organizations must have comprehensive downtime plans available to ensure continuity of patient care during these periods of limited availability. Downtime planning includes strategies to reduce the likelihood of unplanned outages or mitigating their effects with backup and redundant systems to manage availability. It is essential that clinical staff know how to follow downtime procedures through training or even unannounced downtime drills. Organizations must also keep their downtime plans current with frequent reviews, especially following any outage or downtime drill. This review process can capture or correct clinical staff's workflow during periods of limited availability. A comprehensive downtime plan that includes these strategies can become the framework for a set of organizational procedures that ensures the best possible access to vital patient information before, during, and after a downtime event. Thank you for your interest in our research. We'd also like to thank the review committee for their feedback and the conference committee for the opportunity to present this research. If you would like to contact us about this, please feel free to reach out to me directly at joewalsh@uvic.ca. Thank you.